بسم الله والحمد لله والصلاة والسلام على أشرف خلق الله. السلام عليكم جميعا. هذه المحاضرة جزء من مجموعة محاضرات من العناية المركزة بالمستشفى. So is a part of disasters plan aiming for educations of our colleagues in outside ICU who may join ICU in case of disaster, less Allah. So it is about important medications in ICU, and I would try to be very simple, and it is good also for those intensivists. It could be like a refresher slides. So to start with, we can go through medications that is for sedations and analgesia, and can go also through medications that given in delirium, agitations and anxiety, and medications as vasoactive medications, and briefly we can talk about anticoagulations and others. So others will be antibiotic or antimicrobial. This will be in separate lectures as we mentioned before. This lecture is part of a group of lectures that will cover the important topics in the ICU and that could be beneficial to our colleague outside ICU. So to start with medications used for sedations and analgesia, and I can start with the questions. Sedatives do not have which of the following properties? Anxiolytic, B. amnestic, C. inducing slow reflexes, and D. analgesics. So when we say sedative, that means we are talking about sedations and not analgesia. So most of the sedation, most of the time, sedative agent is not analgesic agent. That's why in patients with apparently calm and on sedations, we have to have a tool to check for pain, agitations, delirium, because sedations will not cover these issues, and usually this is overlooked. So sedations and analgesia in ICU, sedations usually goes with assessment. So whenever we talk about sedations, we have to have parameters to assess our medications. Are we giving more or low or less? Analgesia, again, it needs also assessment, and we'll talk about the medication for analgesia, medication for deliriums, and medication for neuromuscular broken agents, and again, it needs also some sort of monitoring. So the ideal sedative drugs in the ICU will be inexpensive, have minimal hemodynamic effects, and minimal respiratory depressions, no drug interactions, produce no active metabolites, and have a short context-sensitive half-life. Also, eliminations will be independent of organ function, so all these could be an ideal sedatives. And because of the pharmacokinetics of our patients are very unpredictable, it is necessary to choose a drug that their dosage is usually given according to the response of the clinical effects that observed. So choose a sedative that is best suit individual patients, and it has many side effects because sedatives are anxiolytic. So my patient shouldn't be anxious, shouldn't be memorizing any memories from the experience of the ICU or painful experience of procedure, etc. So sedatives, as we mentioned before, do not have any analgesic properties except to have two sedations medications like Dexmedetomidine and Ketamine. As we mentioned before, the status of the patients at the optimal level of sedations would be calm, comfortable, and easy to arouse. So unfortunately, it is not often the reality, because ICU care may involve subjecting patients to painful procedures. Okay, as example, patients apparently calm on mechanical ventilators. He may not be well tolerating these issues, and they have otherwise other parameters, scales to judge about his level of sedations or comfortability. So there's three widely used scales for sedations. We have what we call Ramsey sedation scale, Riker sedation scale, Richmond sedation scale. So this is widely used, and in 2013, the SCCM sedations guidelines recommend the use of RAS and SAS because of their validity and reliability for assessing the adequacy of and the depths of sedations. So these patients usually correspond to figure 4 or item 4 in the SAS and 0 in the RAS scale. And this is a brief summary about the three scales that are using. And as we said, it is widely used and validated, and usually they found that it facilitates the dosing of sedative, facilitates decrease of total dose actually, and contributes to decreased time to ventilators, decrease days in the ICU stay, and out of a mechanical ventilator. So this is a RAS, this is widely used. It is also used in our ICU. So extensively validated and most widely used. It attempts to capture the arousal, cognitions, and attentions. The downside for this RAS scale, it is lengthy scale. So 10 items scale will be used to have assessment for cognitions and arousability in these patients. Okay, and this is the other scales, Ramsey sedation scales. We're not using Riker, but they are validated, and other ICUs maybe they're using this one. So here is some common used sedatives in critical ill patients: Diazepam, Midazolam, Lorazepam, Propofol, Dexmedetomidine, and Ketamine. So we'll come shortly separately about these sedations, but we have to have sedation protocols. So whenever we're talking about sedations, we have protocols, as we mentioned before, we have scales, and our strategies here is what we call daily sedation interruption. So we're doing what we call sedation vacations every day, and also the maintenance of light level of sedation. So this is the trend now in many ICUs. The trend is light level of sedation, not like before, and what we call the less is more strategies. Again, when these scales and protocols or strategies is combined with the bedside protocols, for example, nursing implemented protocols that allow filtration of sedations and then predetermined sedation goals, it will be fine, because titration of sedations is a bedside issue and it is very dynamic, and nursing protocol will help much if it's combined with this general protocol. So daily checklist is very crucial. Diazepam is one of the sedatives. It's used only as policies, not on infusions, okay? And it has prolonged sedations in patients with metabolites or renal failure. Midazolam also can be used as bolus or infusions, and it has a downside that it prolongs sedation, especially in patients with hepatic or renal dysfunctions. Lorazepam also can be used both infusions and policies in these doses. Okay, again, organ dysfunctions is a problem, especially renal failure. And Propofol is good drugs, also bolus and infusions once it is quick, but it has also side effects like hemodynamic effects. It causes hypertension, especially in policies, and also profile of the lipids should be checked frequently, and also what to call Propofol infusion syndrome. Dexmedetomidine, has both analgesia, sedative, and also is a good drug. It can be used in policies or infusions, and it has, again, it touches the hemodynamic by causing hypotension and bradycardia. Okay, so it's synergistic with other drugs. Most of the time, it will not stand alone. It has also synergistic effect with other, and also can reduce the dose of, other sedative like midazolam, etc. Ketamine, it has also a sedation effect and also analgesia effect, and there was been attention recently also synergistic effect with Propofol with this dose can be very good and hemodynamically cannot be touched much. So this is a study about daily interruption of sedations, infusions in critically ill patients. It's a good study about interruptions of sedations. It has good effect by decreasing durations of mechanical ventilator days, significantly ICU lengths of stay, hospital, okay? And this a summary about these hypnotics, how they can be chosen and tailored to our patients, especially if we have different kind of patients with hemodynamic instability, renal failure, blah, 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 blah. And you can choose, for example, this drug, the ketamine, since it will not touch the hemodynamic if my patient is in high inotropes, etc., like that. And with this start drugs, usually this means these drugs are limited hypertonia, and they have long sedation effect when used in patients with organ dysfunctions like renal failure. Another a nice timetable about the effects of sedatives, and here also we can have different contraindications, etc. in our sedative. We can go through it. And when we combined this sedation vacation we mentioned before with what we call breathing trials, this study has very good outcome that it decreases 3 days or out of ventilators, and also time to discharge decreases. So ventilator 3 days usually the mean is 14, and then with the control is 11. So significantly it is p-value is statistically significant, okay? Even the mortality is also statistically significant when you combine these vacations of sedations with breathing trial maneuvers. Additional benefit also with daily interruptions paired with awakening, physical occupational therapy, and spontaneous breathing trial. This can give another additional benefits like delirium days is less, time in ICU, ventilator 3 days is more, so all this can give. So we can shift now the sedations, talk about sedations. So definition of analgesia is blunting or absence of pain or noxious stimuli. So shift the gear now to the pain management. Analgesic, and as we said before, sedation is not analgesia. So we define pain as unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So it is subjective. Most of the time it is untreated or undertreated and unrecognized, unfortunately. So we have to have some skills like behavioral pain scales. This can give you a clue about your patient who is sedated, looks calm, connected to many devices around him, around her. So we have this scale giving us the facial expressions, upper limb movements, mechanical ventilators, and if you go with this expression of the face, body movement, you can have a score about 8, for example, which is the worst type of pain. And they found that 70% maybe of our patients experience bad memories, and they can't remember all the painful procedures. So putting in mind the procedures we are doing, the painful procedures, most of the time we can go prophylactically to give analgesia for these patients without assessment. And this is a common drugs for analgesia in ICU: morphine, hydromorphone, fentanyl, remifentanil, ketorolac, and ketamine. We'll talk about them shortly. So morphia, this can be given bolus in this dose or infusions, okay? Again, it can accumulate renal failure and it is histamine release effects. Hydromorphone is the same like this one and has also policies and infusion doses like that. Fentanyl, it has the side effects of causing muscle rigidity, especially if given very fast or larger doses. Okay, so this is the doses, our doses. It can be used also for infusions. Remifentanil is good in some of our drug and have organ failures. They have also good effect. If we have hepatorenal syndrome, this drug is good to have replace the fentanyl ketorolac. We don't have in our ICU. So summary of opioids. This is a good, nice table about the receptors that mechanism of actions, which is also inhibit central nervous system and peripheral nerve, impulses. So we will talk about delirium also, delirium drugs. So to define deliriums, we found that it is an acute disorder of attention and global cognitive functions characterized by acute onset and fluctuation symptoms. And unfortunately, we have 70% of patients experience agitations and delirium with negative outcome. And also, this delirium, they found that in many studies, it has bad effect in terms of ventilator dysynchrony, and increased days in the ICU, increased days in ventilators, increased days in the hospitals. Okay, so it's very important to diagnose and recognize, and it has like 3 types: hyperactive, which is easily to diagnose. Patient is psychomotor, agitated, or hallucinated. The very underdiagnosed one is hypoactive. So patient looks calm, but they have like withdrawn effects and inattentions, and often unrecognized and underdiagnosed. And we have the mixed type, which is combined both. Medications could be possible causes or risk factors with the poison, infection, diabetes, pain, and most importantly also sleep deprivations is very important, or alter sleep better, that can cause delirium. Treatment, usually recognition is very important to modify the risk factors. So good sleep procedures, you have to have a good analgesia, not prone your patients to much pain. Sedations with Dexmedetomidine or Propofol. Avoid benzo. Okay. Antipsychotic drugs is the treatment, haloperidol, ketamine. Okay. And you have to put in mind, whenever you give antipsychotic drug, you have to have checking the ECGs because of the QT intervals, and also it is contraindicated in patients with starting points. And this is the point, this is drug of choice, which will have haloperidol. And this dose can be given IV, IM, or oral. This is the dose. In severe cases, you may also go for infusions. So as we said before, ECG is very important when you are given this antipsychotic, and whenever we have your QT interval, the corrected one is more than 450, you have to have reductions or discontinuations of these medications. Now we can talk about the neuromuscular blocking agents used in the ICU, and it is last resort after optimizing of other therapies. And indication usually facilitate mechanical ventilator, reductions of oxygen consumptions, reduction of muscle spasms, prevention of shivering or control of ICP. And this algorithm about blockade, usually we have your patients assessed for sedations and pain. If it's still inadequate, maybe I will optimize them, increase them. Still not optimized, this is the time to require neuromuscular blocking agents. And it goes here, if you have an organ dysfunctions, I can go with this one, cis-adra. If you're okay, you can go with chromium or chromium. We'll come in a minute to study everyone separately. So the side effects, usually, maybe you heard about the critical care myopathy or critical care neuropathy. This one of the risk factors, one of the factors of the prolonged muscle weakness in the ICU, the awareness also. So monitoring is important. We'll come in a separate slide about how to monitor them. And here is the classifications: depolarizing and non-depolarizing. Depolarizing is acetylcholine, and non-depolarizing we have what we call long-acting, intermediate acting, and short-acting. So the only one depolarizing neuromuscular blocking agent is acetylcholine. It is rapid onset. It is good for intubations or short procedures, and it has these side effects most of the time. The famous one is it's contraindicated with the cases that causing high potassium, like big time burn, stroke, also muscle dystrophy. So we can avoid that, also arrhythmias, and etc. The non-depolarizing neuromuscular blocking agents, we have a group what we call benzyl isoquinoline compound, like atraconium. This is for intubations, dose for intubations. The one that is 2.5 minutes and durated up to 30 or 50 minutes, and it has infusion dose of like that. Cis-atra, this is slower than atraconium. And also one site is 3 to 6 minutes, and it can be given like infusions. The elimination is the same like that one. Also good in intubations. Vicronium also, this is a non-depolarizing agents, but different group, we call it aminosteroidal compounds. So vicroniums for intubation doses like that, and intermediate actions, durations, infusions, doses like that also can go through the kidney and liver. So it can be also prolonged in patients with organ functions. Again, recronium is aminosteroidal compounds for intubations dose, and it is faster actually when given the higher dose, and also it can replace acetylcholine if there is contraindications in the situations of short procedures like intubation. And this is a summary about all we mentioned about non-depolarizing, the onset of actions, the histamine release issues, and etc. The adverse effects here, metabolism is liver, and also we have what we called here the active metabolites, and etc. Sedation monitoring, very important. In neuromuscular blocking agents, we have to monitor what we call the bispectral index. So this is like a mini EEG to produce numerical indicators for the patient level of consciousness, and it is from 0 to 100. And the best one we are using usually the moderate hypnotic general anesthesia. It is 40 to 60 numbers. So usually when we prescribe our neuromuscular blocking agent, usually we mention this number to be on the same page with the nurse, and we can titrate the drug. Vasoactive drugs, we mentioned before, this can be elaborated more in the lectures of shock, but briefly here, norepi is the first line vasopressor therapy in all forms of shock, including COVID-19 shock patients. And usually we can have phenylephrine if there is contraindications. It is not recommended, but if you have contraindication to norepi, like serious arrhythmias, and also if you have cardiac output is good, but still blood pressure is not achieved, maybe there is resistance to catecholamine, so phenylephrine may be a good options. Dopamine in specific patients with bradycardia or risk of arrhythmia, they can have dopamine. Dobutamine in COVID-19 patients, usually in shock patients, if they have hypotension and introduced by noradrenaline, but still they have hypoperfusion, most likely suspicions of cardiomyopathy with COVID-19 is high. So dobutamine could be the best choice here with this dose. So as a summary, norepi is the first line. If no avail, you can go with low dose vasopressin. This is an synergistic effect with norepi. And then the second line could be dobutamine if you have signs of hypoperfusions. Anticoagulations is very important. So low molecular weight heparin should be considered in all patients, including patients admitted with COVID-19, providing no contraindications. And this is the recent recommendations for COVID-19 patients. So we'll go with low molecular heparin according to the D dimers, less than 1 or more than 1, and according to the weight. So here the weight is less than 100, we can go with 40 OD, 100 and 150, 40 twice daily, providing the D dimer. So if the D dimer is more than 1, then I can go with double dosing here, 80 twice daily in big eyes, and 120 twice daily in more than 150 kg. So anticoagulations for COVID-19, all doses may need adjustment and renal failures. And in the absence of bleeding, remember that coagulopathy is not contraindications to introduce your anticoagulations. Thank you very much. We'll see you inshallah in the next lecture. Assalamu alaikum wa rahmatullahi wa barakatuh.